tense due to a mechanical blockage or functional insult. Since it is a deviation from normal as defined, let's proceed with examples of normal imaging of the pediatric abdomen. This is an AP abdominal radiograph of a newborn showing non-distended bowel loops and non-thickened intervening bowel walls. Here is another radiograph of a pediatric patient demonstrating non-distended bowel loops and non-distended bowel gas pattern. For the clinical aspects of abdominal obstruction, most of the disease entities that are covered here will present with these symptoms. The presentation of abdominal obstruction in children varies in intensity. It may be as simple as feeding intolerance to something more notable, such as abdominal distension and vomiting. Vomiting may be bilous or non-bilous in character, depending on the exact level of obstruction relative to the second part of the duodenum, where the ampulla of water is located. Older children, however, may outright complain of abdominal pain. This slide shows a list of possible differential diagnoses for pediatric patients with the symptoms that we have discussed. Evidently, the list is broad and extensive, but if we factor in more clinical data, such as the patient's history and age, we can narrow down the possibilities. Here are the possible differential diagnoses for a 9-year-old girl with obstructive symptoms who was previously well. The clinicians would more likely consider an inflammatory process, such as appendicitis, over a congenital disease entity like duodenal atresia. Moving on, in a 2-day-old boy with obstructive symptoms, the clinician would then favor congenital causes of obstruction, which brings us to the main chunk of this presentation, the congenital causes of obstruction. Outlined here are the parts of the presentation, starting with the esophagus down to the colon. Let's proceed with esophageal atresia and tracheoesophageal fistula. During normal embryonic development, the primitive foregut begins to form a groove at around 4 to 6 weeks age of gestation. This groove will eventually form a septum, creating a lumen, creating 2 separate lumens, and further cell proliferation and apoptosis will create 2 distinct tubes, as shown here. This is a graphic representation showing the normal and anatomic relationship of the esophagus and the trachea. Again, they are 2 separate tubes without any form of connection. Now, any anomaly in the embryologic process that we have discussed may result into esophageal atresia with or without tracheoesophageal fistula. The most common of which is the proximal esophageal atresia here with distal tracheoesophageal fistula. Here is a rate of a neonate with a properly positioned feeding tube overlying the visible gastric bubble. The feeding tube distal tip here in this patient is high-lying. The patient had history of inability to pass feeding tube. Here's another radiograph of a high-lying feeding tube, this time looped in the proximal esophagus. This is suggestive of esophageal atresia. This is a contrast-enhanced study of the esophagus showing esophageal atresia without any fistula. This procedure is called the pouchogram. Here's another example of a pouchogram in AP and lateral views labeled as A and B respectively. Here is an example of a contrast-enhanced radiograph in a patient with distal tracheoesophageal fistula, allowing the passage of contrast into the carina and subsequently into the bilateral main bronchi. Let's proceed with the next part of the lecture, small bowel obstruction, starting with duodenal atresia. This is a graphic representation of the normal process of small bowel formation. The primitive foregut begins as a hollow tube, as seen here. The endodermal cells, will occupy the lumen and proliferate, including the lumen, and they will eventually apoptose, leaving velus structures behind, forming the normal anatomic bowel loops. These are the clinical features of duodenal atresia in addition to the obstructive symptoms that we have discussed earlier. Patients may present prenatally with polyhydramnios due to the inability of the fetus to normally consume the amniotic fluid. Vomiting may be bilous or non-bilous in character, depending on the exact location of the exact level of the obstruction. Here is an abdominal radiograph showing the double bubble sign. Marked with an asterisk here is a distended gastric bubble, and pointed with the arrow here is the distended duodenum. This is an example of cross-sectional imaging. Letter A is the image on the radiographic right. Table last A is a sonographic imaging showing double bubble sign with a distended stomach here and the distended part of the duodenum here. Image B is on the radiographic left, is a MRI T2-weighted image showing double bubble sign, distended stomach here, and the distended portion of the duodenum here. Let's proceed with duodenal web. Duodenal web is, as defined, is a presence of redundant mucosa, smooth-walled mucosa within the lumen of the duodenum. The radiographic right is a normal example of a duodenum, contrast enhanced, showing the normal velus structures. On the radiographic left is a contrast enhanced image of the duodenum with the presence of a pouch within, smooth-walled pouch within overlying the normal mucosa. This is the so-called Winsock sign attributed to the apparatus of the same name. Next, we have malrotation and medial volvulus. Malrotation is defined as a congenital and anatomical anomaly that results from abdominal rotation of the gut as this returns to the abdominal cavity during embryogenesis. While volvulus is a twisting of the intestines around itself and its mesentery. These two are separate clinical entities and does not necessarily always occur in concurrence with each other. Malrotation predisposes a patient to volvulus but may also occur on its own. This is a graphic representation of the normal process of gut rotation. The primitive gut, as seen here, begins as a straight tube but eventually starts to protrude and herniate into the umbilical cord, where rotation of about 270 degrees will start and will continue within the abdominal cavity, resulting into the normal and anatomic configuration of the bowels, where the cecum is located in the right lower quadrant. Any deviation from this normal process may lead to malrotation. The image labeled as A here on the radiographic right is an AP image demonstrating a normal duodenal course. With the normal positioning of the ligament of Treitz. The duodenum should cross the left of the midline. as demonstrated here. The image labeled as B on the radiographic left is the lateral view of the same duodenum, showing the posterior location of the third part of the duodenum, just anterior to the spine. Next is a spot film from a barium study in a patient with malrotation and midgut volvulus, demonstrating the abnormal location of the duodenojejunal flexure not crossing the midline, and the corkscrew appearance of the duodenum and jejunum suggestive of midgut volvulus. This is a fluoroscopic imaging in a child with midgut volvulus showing a tapered beak as pointed by the arrowhead at the site of obstruction in the third portion of the duodenum. Another useful radiographic clue is the relationship of the SMA and SMV. Normally, the SMV is more in the right, as shown here, and the SMA is more in the left, as shown here. This is a sonographic imaging showing inverse anatomical relationship of the SMA and the SMV, suggestive of malrotation. We can see here that the SMA is more on the left, on the right, and the SMV is more on the left. And here is a CT scan image also demonstrating inverse SMA here and SMV here. Next is annular pancreas. This is a graphic representation of the normal relationship of the pancreas and the duodenum. Annular pancreas, as shown here, is a result of the failure of migration of the pancreatic bud around the duodenum, resulting into encroachment of the external walls of the bowel, which may lead to obstruction. This is a sonographic imaging of a patient with annular pancreas, showing the duodenum being surrounded by the pancreatic tissue, pointed by the arrows. Moving on to jejunal and ileal atresia. The pathophysiology of jejunal and ileal atresia closely resembles that of duodenal atresia, but some suggest that a vascular insult may be a factor in such that ischemia can cause failure of recanalization and thus obstruction of the lumen. This is a plain radiograph demonstrating the triple bubble sign, representing the distended stomach here, distended duodenum, and the distended portion of the jejunum. An additional sign that can be encountered on radiograph is the presence of peritoneal calcifications, as pointed by the arrows here. This finding indicates that there has been an in utero bowel perforation with spillage of meconium into the peritoneal cavity, resulting in inflammation and resultant calcification. Proceeding to meconium ileus. Meconium ileus is a neonatal obstruction of the distal ileum by retained meconium and is likely secondary to abnormally viscous intestinal secretions and meconium, resulting in obstruction at the ileocecal valve. This is an image from a contrast enema showing diffusely small caliber colon here, consistent with microcolon and multiple filling defects in the terminal ileum, representing meconium. A contrast enema with water-soluble contrast is both diagnostic and therapeutic, as it also loosens up the meconium, allowing it to pass through the colon. Moving on to colonic obstruction, starting with small left colon. Small left colon is also known as functional immaturity of the colon. and meconium plug syndrome. This occurs in infants of diabetic mothers and in infants whose mothers receive tocolytics, specifically magnesium sulfate, during pregnancy. Radiographs will demonstrate dilated proximal colon with an abrupt caliber change, usually at the level of the splenic flexure here. Filling defects in the more proximal dilated colon represents the retained meconium, as shown here and here. Colonic atresia, like the previously discussed atretic diseases, may be due to failure of recanalization or from a vascular insult. This is a radiograph from a contrast enema showing small caliber distal colon with no further contrast enhancement beyond the distal half of the transverse colon. Findings are consistent with colonic atresia. Hirschsprung disease. The pathophysiology of Hirschsprung disease involves failure of neural crest cell migration affecting the enteric nervous system and thus its normal motor activity. The rectosigmoid ratio is often described as diagnostic measure for Hirschsprung disease. Normally, the rectum is larger in diameter than the more proximal colon. However, in Hirschsprung, the rectum and the aganglionic segments of the colon are smaller in caliber compared to the unaffected segments. Image labeled as A on the radiographic right demonstrates a small caliber rectum, is pointed by the arrow here, and dilated colon more proximately with marked with an asterisk here. This represents an abnormal rectosigmoid ratio, highly suggestive of Hirschsprung disease. The image labeled as B is a lateral view confirming the findings with a small caliber rectum and dilated more proximal colon. Lastly, imperforate anus. Perforate anus is failure of normal development of the hindgut, leading to anorectal malformation and or imperforate anus, resulting into distal colonic obstruction. The condition is usually clinically apparent and clinically diagnosed, with absence of anal opening on physical examination. Imperforate anus is frequently associated with fistula formation, rectovesical or rectourethral in boys, and a more complex malformation involving the rectum and genitourinary system called the cloaca in girls. Anorectal malformations are often accompanied by other anomalies as part of the factor association. And as such, skeletal malformations may be a part of the imaging findings in imperforate anus. Here is an abdominal radiograph in a neonate showing dilated loops of bowel due to obstruction from an anorectal malformation and imperforate anus. There is note of this plastic appearance of the sacrum as pointed by the arrow here. And that ends my presentation. Thank you.
Thank you so much, Chester. Could you go back to your slides
Yes,
for
but
the rotation and volvulus? We have a few minutes left, so let's make use of that time. Thank you so much for showing the normal abdominal x-rays from the neonates to the older child and adulthood. Let us remember, dear residents, that for neonates, it is very hard to differentiate or to delineate the small intestines from the large intestines. So you really have to carefully tell if it is just ileus or if it is already an obstruction. So could you go back, please?
Here pa lang. Malrotation and midgut volvulus.
Sige, isa-isahin natin yung images.
Mm. Here's the definition po of malrotation and volvulus. The graphic representation po, Doc, of the normal development of the gut.
Okay, sige.
Here.
All right there. Okay, just to tell our residents, what do we use to objectively measure a distended abdomen, a distended intestine, either small or large in a neonate? What we use is the interpedicular distance, like right here. So if let's count that this is the T12, we count 1, 2. You try to measure the interpedicular distance of the L2 vertebral body, and roughly that will give you the maximal estimate of the supposed normal distension of a intestine. So ito, imagine natin yan. Let's say ito 1.8 cm. This one is 1.6. So still can be considered within normal luminal distension. So that's how we objectively measure distension in neonates, because at that time, hard to delineate if it is small, if it is large, if it is markedly distended. Through time, through reading so many x-rays, you will get to decide immediately if it is already obstruction. You don't need to measure. But right now, kindly follow this objective way of knowing if an intestinal segment is dilated. That's one of the process. Now, Chester here provided a very beautiful representation of a normal, what you expect in an upper GI series with a normal duodenojejunal junction. Starts going to the right of the patient, goes down, that is the second segment. The third segment crosses the midline and slightly goes up, much like a smile sign, and the duodenojejunal junction is the one pointed by the arrow. Now, our pediatric surgeons come to us saying, may ipapaugis ako kasi I'm ruling out volvulus. Okay, so whenever you receive that referral, pag gagawa tayo ng ugis, we need to be accompanied by a surgical resident at least. Pero pagka patient ni Dr. Katanggi, siya na ang sumasama. Pero if not Dr. Katanggi ang pediatric surgeon, if they are ruling out volvulus, please ask for a surgical resident to accompany you during the procedure, because it's an emergency case. So, hindi ka na maghahagilap kung nasaan sila. And right there and then, you can talk and decide if it is really a volvulus. Okay. So this is the normal Chester. Next natin.
Corkscrew sign po, no?
Oh, thank you. Very beautiful. Thank you for showing this. This is a classic example of volvulus showing the corkscrew sign. Yan, hindi mo na kailangan ituloy pa yung study. You see this, surgery naman daw sa kanila. Okay, very good. Kaya we need at least the surgery resident to be with us during the procedure, because they already have the clinical hunch that they are dealing with the volvulus. They just need confirmation from us. So, walang gagawa ng ugis, rule out volvulus na kayo lang. Next natin. Big sign. Yes, you're pertaining here to a big sign. It could either be a complete big sign, complete obstruction, either internally or externally. Internally, it could be a web, it could be stenosis, either intrauterine, yes, vascular insult, or extra. Well, For intraluminal, mostly intrauterine yan. Pagka naman other causes ng extraluminal big sign could be annular pancreas, it could be a markedly enlarged lymph node, it could be a retroperitoneal mass. Anything could happen. So follow-up modality after this ultrasound, or if more if the finances permit, MRI. Kasi mga bata, we refrain from using CT scan, di ba? Ay, sorry. Next natin. Okay, CT scan, yes. Lumabas yan sa Battle of the Brains, annular pancreas. Well, now you know. Next. Okay, very good representation. We don't usually look for this, but now that you are aware, madali lang naman siya. Maybe we could do a hands-on on this because right now we have residents doing hands-on for ultrasound. So maybe we can do a rounds and let you find this image. Okay, Chester, punta tayo dun sa colon.
Okay pa.
Mm-mm-mm-mm. Okay,
Small
for
left colon.
colonic obstruction, yes, yes. Small left colon. For small left colon, it could either be meconium plug syndrome or functional immaturity of the colon. You were very right when you said that there is this inspissated meconium at the left side of the colon, causing non-distension of the distal descending, rectosigmoid, and anything beyond that. But once the meconium is removed, it can revert back to its original shape and function. So that's the definition of the meconium plug. Remove it, goes back to normal. Functional immaturity of the colon, it just pertains to immature mesenteric plexus ganglia. Can be done only with biopsy. Okay, but if you just say that it is a small left colon syndrome, you are still correct. Okay, tingnan natin yung iba.
Colonic
Okay.
atresia daw.
Colonic atresia. Of course, atresia, you're very good in saying that there is failure of recanalization. The same idea from small intestinal, duodenal, ileal, jejunal to colonic. There's failure of recanalization. What is important here from all the images that I've shown you, uh, dear residents, please have the presence of mind to differentiate if it is upper gut obstruction or lower gut obstruction. Chester beautifully depicted that all upper gut obstruction needs upper GI series and all lower gut obstruction needs barium enema. And he was able to clearly present the sample cases for upper gut obstruction. He was able to do it, enumerate them one by one, painstakingly enumerate them one by one. So kindly apply them to your practice, upper gut obstruction versus lower gut obstruction. So everything at the end of here is the lower gut obstruction, colonic obstruction. Okay? So can I share a screen sandali?
Yes pa daw.
Because I want the residents to look for this journal. This one. Can you see this? Before tayo
Yes
maghiwa-hiwalay
daw.
and sign
Apo.
off. Dear residents, one of these days, siguro mga random questions. I'd ask you about the patterns of microcolon, imaging strategies for diagnosis of lower gut obstruction in neonates. Kindly look for this article, very helpful, that once you do barium enema, you'll be very much guided on what to expect. Kasi ganun tayo sa radiology, we already have differentials in mind. When we do a certain procedure, we already have differentials. So, nakaset na yan, nakalista na yan sa utak mo. So, of how it is done. Okay, guys? Chester, very good. Thank you so much. Have a good week, and everyone. May